Good afternoon. My name is Mark Ruel. Welcome to Science News. Today I have the honor to have with me Dr. Jane Neuberger and as well Dr. Robert Harrington. And we will be discussing some of the findings and new data that was presented this morning at a session entitled Novel Findings from Next Generation Registries. Good afternoon, Jane and Robert.
Thanks for having us.
Welcome to Science News. Jane, let's start with you. I wanted to get your thoughts about a fairly provocating set of data that were presented about increased incidence of infective endocarditis after the 2009 ESC guidelines update. And this was a nationwide study coming from the Netherlands. And perhaps if you could give us some of your take on the study and your impressions as to how this may affect the adherence to the new guidelines.
The European Society of Cardiology guidelines were released in 2009 and followed actually the American Heart Association guidelines in 2007 and guidelines from the United Kingdom in 2008 that cut way back on the use of antibiotics with dental work. So that whereas most patients previously got a dose of antibiotics before they sat in the dentist chair if they had a structural heart lesion, now only a very few groups of very high-risk patients get it. And the seminal question is whether this change in the guidelines is causing more cases of endocarditis after dental work with the type of organisms that live in your mouth. What the authors found was that the incidence almost doubled between 2005 and 2011, which was the period of time that they surveyed an insurance database. And that there was especially sharp, the rise really began in 2007, and maybe there was a slight increase in that after 2009. The questions are, just by way of background, that first, endocarditis has been going up broadly, not just in the Netherlands, but also in the United States and in the United Kingdom. And there are many different possible explanations. First of all, there are more predisposing factors in our population. We have more elderly with structural heart defects, more patients with prosthetic devices, and more predisposing conditions like diabetes, renal failure, etc. So it's possible that this is going up simply for that reason. It's also possible that there are differences in, or more accuracy in the coding of endocarditis that is allowing us to ascertain cases ever better than we used to. To really answer the question, that the central question is whether the guidelines themselves are responsible for this increase. And in order to know this, we need to know more than we could find out only from this particular registry study, which sets the stage, I think, for more questions. We would like to know what the organism is, if there's actually an increase in the type of bug that lives in your mouth, which is oral strep viridans. We also need to know whether patients actually were or were not following the guidelines. Did they take the antibiotics or didn't they? And then finally, we need to know whether the patients who got endocarditis from oral strep actually even had a dental appointment. So I think the registry approach, having the registry, sets a great background for doing either a clinical trial, randomized trial, within subjects or patients followed in that registry, or even a really detailed case control study where you delve backwards to find out much more about the cases of endocarditis and carefully matched controls.
Jane, these are very seminal points that you raised and that you raised earlier this morning. Do we even have a sense as to what the level of adherence is to the new guidelines? I can tell you from a personal point of view, and I mentioned this morning, moderating the session, as a surgeon, we do as a community tend to be very conservative. We see our patients who come back with endocarditis, and we're very wary of anything that could lead to an increased incidence of it. So I think amongst our community, and certainly when we get asked our opinion, which is not 100% of the time, but certainly our patients do call about this, we always tend to promote a more conservative approach in line with the previous guidelines. Do we know what the adherence level, perhaps in the US or in other countries, has been?
We don't know, we certainly didn't know in the Netherlands study for sure. And it is true that the guidelines in the Netherlands were released in 2009. If you look carefully at the incidence curves, they started going up very rapidly in 2007. So that also makes you wonder whether really it's the guidelines themselves or something else. But I agree, physicians are very conservative with their patients, and they hold on to tradition for a while. I think in England, where there's a National Health Service, we do know, not so much for individual patients, but we do know that prescriptions before dental work went way down after their guidelines were released.
May I ask you the $1 million question? What is your own personal recommendation?
My own personal recommendation is not to use the antibiotics for average risk structural heart disease. I think for patients who would be especially sick, if they developed endocarditis, people with prosthetic valves, cyanotic heart disease are two good examples. Those individuals, I would continue it, even though I'm not sure that it's necessary. But for the average person, there's such a low risk, such a tiny proportion of cases that could be attributed to dental work, that the adverse effects of the antibiotics, I personally believe, are probably worse than the risk of getting endocarditis from a dental procedure.
Jane, these are very wise comments. Thank you very much, and I'll certainly take your advice with great attention and certainly study it very carefully. Let's switch gears to another presentation that was delivered this morning. Robert, about the appropriate use criteria for coronary revasc and looking at trends in utilization, patient selection, and appropriateness of percutaneous coronary intervention, so PCI. And these were findings from I would say, the nationwide, perhaps not completely exhaustive, but encompassing most of the PCIs in the US as they are captured in the NCDR CATH PCI registry. What was interesting there is that those AUC criteria do evolve over time and perhaps become more stringent. I'd like to get your feel as what you thought of the study and what it means with regards to PCI. Is it applied appropriately? Are there still strides that we can make to make sure that quality and indications are optimized based on the AUC?
Yeah, so this was, I think, an important piece of work that came out of the Health Services Research Group at Yale, where they looked, as you've said, Mark, at a temporal analysis of angioplasty being done in the United States. I think they said about 3 million angioplasties over this period of time, over this number of years. And what they demonstrated was that if you applied the appropriate use criteria from about the early to midpoint of that analysis, if you apply the appropriate use criteria, meaning was it appropriate, was it not appropriate, inappropriate, or was it uncertain? If you applied that to these PCI procedures, and you look specifically at the non-acute, so the non-acute coronary syndrome angioplasties, what they demonstrated is that there has been a decline over a period of 4 or 5 years in the absolute number of patients who would be undergoing a non-acute PCI. So that's the first observation. The second observation is that they show that the percentage of those non-acute PCIs that were coded as inappropriate are also dropping, leading the authors to the conclusion that the introduction of AUC criteria, or appropriate use criteria, into American practice, and in some ways tying it to our quality improvement registries, et cetera, has been associated with fewer inappropriate procedures being done. Now, there's a lot of caveats in this. Number one, there's questions raised about, does this really reflect a change in the way people are doing procedures, or does it affect Does it reflect a change in how they code their procedures? And both the author acknowledged that as well as the commentator, the Ray Gibbons from Mayo noted that this morning. But even if you consider that, it still does appear that over a period of time that attention is being paid to the AUC and that there are fewer inappropriate procedures being done in the U.S., which is a good message. I actually wrote the editorial that accompanied the paper that came out in JAMA today, and I noted that this is a bit of good news, that where cardiology, particularly interventional cardiologists, where we're sometimes criticized for doing too much, this was an example of where the community responded to the evidence and began to perhaps follow the guidelines and the appropriate use criteria a bit more carefully. Now, there were, in addition to the caveats I've mentioned, there's also some unanswered questions. The biggest one being, is this a widespread effect across the country? Well, first off, not everybody participates in the registry, and many people have pointed out that this is potentially problematic. If we don't know how all the procedures in the country are doing, how can we make system-wide changes? And the second issue has to really do with, are we just seeing a shift from how people coded, as I said earlier, their procedures? Are we truly seeing more acute procedures, or are we truly seeing fewer non-acute procedures? And I think some of those details have to be worked out.
These are great points. Robert, do you think some of those AUCs could be taken further? And what I mean by that, would there be a point in encouraging and making a determination appropriateness around having a heart team discussion, for instance, in patients who have multivessel coronary disease, especially when they have stable coronary heart disease, or multivessel disease patients who have diabetes as well? Many institutions around the world, and certainly the guidelines, support that a heart team discussion occurs, and that a syntax score in many cases should be calculated as well. So do you think there's room for the AUCs to grow and be even more reflective of the appropriateness of PCI interventions?
Yeah, I think you're raising really good points, and as you've rightly said, you're one of the authors of the revascularization guidelines, the CABG guidelines. And in the CABG guidelines, it actually does tell us that there are certain groups of patients, high syntax score, diabetes with multivessel coronary disease, that bypass surgery might be more appropriate. You do see in the AUC that you can begin to parse if your patient has syntax score of a certain level, or if your patient has these other concomitant diseases like diabetes, then perhaps the coding of a PCI might fall into one of those categories of either, of rarely appropriate. So yes, the AUC criteria can absolutely consider that, and it can really take into consideration your earlier comment about the heart team as well. That if you don't have a heart team discussion, does it automatically drop you down the list of appropriate? I think that would be something worth discussing.
One quick question. It was interesting to look at the numbers of PCI performed within the registry, and these have come down over the last 4 or 5 years. Do you think this really reflects a trend, or is it that some centers got out of the registry, or what do you think that means?
So this has been looked at, and if you look across the U.S., it looks as though the numbers of percutaneous intervention are down across the country, largely driven by fewer being done in stable patients. And I think that reflects, in part, a change in the practice of very aggressive medical therapy. And the guidelines now say in stable CAD that you either have to have refractory or persistent symptoms which are interfering with somebody's quality of life, or you have to have some demonstration of severe ischemia that might push you towards such an intervention. And as you probably know, we're involved with an NHLBI-sponsored trial, ischemia, that's trying to ask that very question, that if you can medically manage someone with stable CAD, even with a moderate to severe amount of ischemia, do they actually have to go to the cath lab at all?
Well, it sounds like there are good news, and we're heading in the right direction with regards to finding the appropriate indications for PCI.
Yes.
Let's touch upon a third study that was presented this morning, which was entitled Examining Prevailing Genotype to Phenotype Correlations in HOCM, or Hypertrophic Cardiomyopathy, Findings for the Sarcomeric Human Cardiomyopathy Registry. And this was presented by Carolyn Hull from the Brigham and Women's Hospital. And Jane and Bob, any comments about this study, which showed very interesting, if you will, mechanistic correlations between the outcome of those patients and their genotype?
Go ahead now.
I should, as a caveat, say I'm not either a myopathy or geneticist person, but I thought it was a fantastic demonstration of phenotype-genotype correlation. What we're understanding now about hypertrophic cardiomyopathy is that sarcomeric genes, that the presence of mutations in sarcomeric genes portends a more serious clinical course than other types of mutations or the absence of mutations. And eventually, this will also, you could imagine a time when we'll be able to actually tailor therapies to the types of mutations, be more aggressive in the more malignant types. We don't know yet whether that's possible here, but this was a great first step.
Yeah, for me, the takeaway, and like Jane, this is not my defined area of expertise, but if I think about it from the perspective of a clinical investigator, this is a disease, hypertrophic cardiomyopathy, that most of the literature involves small samples, largely coming from single centers. And I think one of the astonishing things that this group did was that they convinced a number of these centers from around the world to take their very well characterized data and put it all together. Right. So now for the first time, instead of seeing a few dozen or even a few hundred patients, it was over 5,000, it was almost 6,000 patients. That's extraordinary. And then it allows the kind of work that Jane's talking about to more carefully correlate the genotypic expression with the phenotypic expression and begin to more precisely help us with the diagnosis, with the risk characterization, with counseling to the family, and then ultimately maybe even with tailoring therapy. So I thought this was a fabulous presentation.
Absolutely. A step in the right direction. We certainly know that these patients need everything we can offer them because it is a relentless disease that affects the young, and certainly this is quite a stride forward. Jane, Bob, I would like to thank you very much for presenting your insights and your comments about these groundbreaking studies that were presented this morning at the late-breaking clinical trial registry and observational studies registries of the American Heart Association. This is Science News, and it is recorded live from the scientific sessions of the American Heart Association. Thank you very much for your attention.
Thank you.